Hello, my name is Alexandra Hanna, and I'm a fourth-year audiology graduate student from the University of Cincinnati. I worked alongside Dr. Catherine Bachman and Dr. Lisa Hunter for the following study. The study I will be presenting to you today is titled Comparison Between Results of the Video Head Impulse Test and Dynamic Visual Acuity in Pediatric Vestibular Patients. I'd like to start by reviewing some background information and some phrases that you should become familiar with before we proceed. In the general population, 1 to 5% of children have vestibular disorders. In children diagnosed with sensorineural hearing loss, up to 70% of them will have vestibular loss as well. One of the main phrases that I will be using throughout this presentation is vestibular ocular reflex, otherwise referred to as VOR. The VOR is a reflex that is mediated through stimulation of semicircular canals. It is responsible for maintenance of clear vision while the head is in motion. So while the head is in motion, the semicircular canals in that plane of motion will send messages to the ocular motor nuclei, whose nerves innervate the muscles of the eye, which then generates a reflexive response equal and opposite to that head movement. Two tests which rely on a functioning VOR are the Video Head Impulse Test, referred to as vHIT, and Dynamic Visual Acuity Test, DVA. The vHIT is high-frequency head impulses to measure VOR gain. VOR gain is basically a measure of how much the eyes move to compensate for the head movement in order to keep the eyes focusing on a target. During vHIT, the head is moved at peak velocities of 150 degrees per second while the patient is asked to fixate on a target. In healthy patients, the eye movement compensates for the head turn, allowing the eyes to fixate on that given target. In those with VOR loss, the lack of input to VOR results in the eye moving with the head. Like vHIT, DVA is a measure of gaze stability while the head is in motion. But further, it measures visual acuity changes in the presence of head movements. So during DVA, the head is moved with velocities between 95 to 130 degrees per second, while the patient is asked to indicate the orientation of an optotype E that is displayed on a computer screen. In healthy patients, the VOR allows the images to remain stable on the fovea during that head motion, and the optotype orientation is recognized easily. In those with VOR loss, they are unable to maintain stable gaze during the head motion, causing a reduction in DVA. This first picture displayed on the left side of the screen is an example of vHIT. You can see that as the patient's head is moved to the right, his eyes are deviated to the left. This patient is focusing on a given target. This is an example of a normal functioning VOR. The picture displayed on the right is an example of the optotype E that is displayed during DVA testing. The main goal of our study was to determine the correlation between the results obtained on the vHIT and DVA test in children with vestibular dysfunction. The test battery for pediatric patients is already lengthy, so we would further like to know if both vHIT and DVA testing is necessary, since both of these tests evaluate the VOR. Our study was a retrospective chart review that looked at charts of children between the ages of 0 to 18 years of age who were seen at Cincinnati Children's Hospital Medical Center. These patients had a chief complaint of dizziness and had a vestibular evaluation and a vestibular rehabilitation evaluation at the Pediatric Balance Center of Cincinnati Children's. These patients underwent both vHIT and DVA testing and had a variety of diagnoses, which included, but was not limited to, bilateral sensorineural hearing loss, unilateral hearing loss, whether that be sensorineural, conductive, or mixed, and migraines. Some of these patients had a normal VOR, while others had a peripheral and/or central vestibular pathology. The data used was collected by electronic chart review, extracted, and incorporated into a secure password-protective database. Results of vHIT and DVA testing were then compared. While looking at these results, We looked at them in conjunction with the finding of the child's diagnosis, whether that be normal, central, or peripheral. We then used the Fisher's exact test to determine significance. This test is a statistical test used to determine if there are non-random associations between two categorical variables. Now moving forward with our results, we had a total of 33 subjects. Of the 33 subjects studied, DVA was abnormal in 25 of those subjects who had complaints of dizziness, while vHIT was abnormal in 6 of them. These subjects were then divided into one of 3 groups based on their diagnosis: normal vestibular function, peripheral vestibular dysfunction, or central vestibular dysfunction. The figure displayed on this slide allows us to have a good visual representation of the results. This figure shows the % abnormal results for DVA and vHIT for each diagnosis group. As you may see, DVA testing resulted in more abnormal findings in all 3 categories compared to vHIT, especially when there was an abnormal finding in peripheral and central dysfunction. From these results, we concluded that DVA testing has higher sensitivity to vestibular dysfunction compared to vHIT. This next table breaks down the Fisher's exact test. As you can see in red, the only significant result found with our studied 33 subjects was comparing central versus peripheral results of vHIT testing. Now that we have reviewed the results, I'd like to dive deeper into our discussion. As stated previously, we found that DVA had a higher sensitivity rate compared to vHIT. But we also found that vHIT had a higher specificity rate compared to DVA, meaning that with 100% of normal semicircular canal function, vHIT was normal 100% of the time. These findings were in agreement with reports of high specificity for vHIT in regard to peripheral vestibular dysfunction. When looking at subjects with peripheral pathologies, there was a higher percentage of abnormal DVA results than vHIT results. Abnormal vHIT results were only obtained in 42% of those subjects, while DVA abnormal results were obtained in 67%. A study conducted by Smith in 2013 reported that there are projections to the brain from the peripheral vestibular end organ. One of the structures receiving these projections is the hippocampus. One of the main roles of the hippocampus is our memory. When the vestibular input is diminished, the hippocampus is affected, and thus our memory is affected. When our memory is impaired, spatial tasks, such as those seen in DVA testing, can become more difficult to accomplish. This could help explain the higher abnormal DVA result in the peripheral dysfunction group. DVA abnormalities were also found in the normal and central vestibular dysfunction groups. However, with a high percentage of those in the central vestibular dysfunction group having abnormal DVA results. This would seem to indicate that the DVA test not only relies on normal peripheral vestibular input to be normal, but it is also dependent on normal central vestibular pathway function. DVA was more sensitive to central vestibular pathway involvement and more in line with the patient complaint of dizziness. Even in the normal vestibular function group, meaning those who did not have peripheral or central findings, abnormal DVA was able to validate the patient complaint of dizziness and uncover dysfunction in the central nervous system, either in central vestibular pathways associated with the VOR or higher cortical centers. It can be determined that DVA testing does take more cognitive skill compared to vHIT. Unlike DVA testing, vHIT does not require the same visual spatial ability, thus it requires less cognitive function and ability. DVA results also appeared to agree more with patient complaints of dizziness compared to vHIT. So in conclusion, both tests should still be completed in the pediatric vestibular test battery. While DVA was more sensitive to vestibular function overall, the DVA results are non-localizing, where the dysfunction could be peripheral or central. In the case of abnormal DVA, vHIT may help determine the site of lesion or at least rule out the peripheral vestibular end organs. To kind of wrap everything up, we know that this study only had 33 subjects. So future research could include increasing the sample size in each diagnosis group to add more statistical power. Future studies could also even evaluate changes in DVA performance in the normal and central diagnosis groups following vestibular rehab, as well as even comparing vHIT and DVA scores for the peripheral dysfunction group following rehab as well. I'd also like to just say thank you again to Dr. Catherine Bachman and Dr. Lisa Hunter for all of their help in completing this study.